Good morning, everyone, and welcome to the Digestive Disease Update 2025. I apologize I couldn't be with you today, but I promised to record something. I was tasked to present about the subject of pancreatic surgery for benign pancreatic conditions. Basically, a little summary about what we're going to achieve today. I took advantage of this to talk a little bit about our program history and how we started at VHC with our HPV program, and then talking a little bit about anatomy of the pancreas, and then I'll go into the benign lesions of the pancreas and the precancerous lesions of the pancreas for a little bit, and then mainly at the end talk about surgery for pancreatitis, and then at the end some thank you for the teams. I have no financial disclosures. So we basically started in 2015, Dr. Timothy Shaver and I. Dr. Shaver has been here for about 35 years doing liver and pancreas surgery in Northern Virginia. I basically trained with them at Fairfax Hospital as a resident, and then after my fellowship, I came back to join his practice. Virginia Surgery Associates was the main practice. We were 18 surgeons at the time, basically based out of Fair Oaks. We were in private practice. We did basically everything across Northern Virginia. We went to every single hospital, and then the pandemic hit. VSA ended up joining Innova in the spring of 2021. Dr. Shaver and I basically thought about what to do next, and we decided not to do that. And we basically started going to Reston Hospital during the pandemic. It turned out to be that Reston Hospital to us was a very stable place and well-equipped place to continue doing our surgeries and to transfer our program during the pandemic. And once the pandemic was over, we basically were at the point where Dr. Shaver was ready to retire and I needed to keep going. And this is when we transferred the program to VHC. Started at VHC in August of 2023. Did my first case, I think the first week of August of 2023. Dr. Shaver came with me. He's part-time. He's semi-retired at this point. He does weekend coverage, and I then became the medical director of HPV surgery at VHC. And we basically hit the ground running. We did anything basically in the last 2 years, from biopsies to major cases. Since then, I have about 600 cases from the American College of Surgeons registry. In about 2 years now, 277 liver cases, 105 pancreatic cases, 70 of them are Whipples. We did liver ablations all the way up to Whipples with vascular reconstructions. I have a picture here on the side about the case I did last month when we did a Whipple with portal vein resection and reconstruction with bovine pericardium. So we basically brought the game to a whole different level at VHC. Next is a little bit of anatomy. These slides are basically mine. We paid someone an artist to draw us these pictures, so these are ours. The pancreas is this organ that's really deep in the abdomen. And when I tell patients about it, I always say, think of it as it's sitting on your spine. It's not really in the front of your abdomen. It's really in the back. And it's very tricky. It's surrounded by all these organs. The stomach, the liver, the gallbladder, the small intestine, the spleen, etc. And it's sitting around big major blood vessels, the superior mesenteric artery, the portal vein, the superior mesenteric vein. So surgery on the pancreas is very tricky. Basically, so this is when I remove the stomach here on the right side, we see the actual anatomy of the pancreas. And to most people in the community, the pancreas has a head and a tail. To us, it's a little different than that, basically. To us, it has 5 different regions or areas or parts, from the uncinate process down by the main vessels here medially, and then it has a head, a neck, a body, and a tail. Pancreatic surgeons look at it this way. We have the distal bile duct, or the bile duct, going through the head of the pancreas to meet the small intestine at the ampulla. We have the tail of the pancreas basically hugging the hilum of the spleen. So many organs are basically included in any type of surgery on the pancreas. Surgery on the pancreas, for the most part, in our practice, is surgery for malignant lesions. However, for the purposes of this meeting, I was tasked to talk about benign lesions, which is probably about maybe 10 to 15% of what we do, but it's super important. And I always say to patients, I'd rather operate on cancers versus pancreatitis per se. And I'll get to tell you on why is that. Next, benign pancreatic surgery for non-cancerous conditions include surgery for benign lesions of the pancreas or precancerous lesions of the pancreas. We have a multitude of those. Basically, I'm mentioning the most important ones, or the most common ones that are still really not common that we operate on. IPMN, so we can classify cysts of the pancreas into mucin type cysts and serous type cysts. The mucin cysts contain mucin, basically, and they are precancers. It's either an IPMN, which is intraductal papillary mucinous neoplasm of the pancreas, or an MCN, a mucinous cystic neoplasm. They differ a little bit in how they start and what they're made of, and the risk of progression into a cancer. The main duct IPMN is basically a small tumor blocking the either the main duct of the pancreas or the branch duct of the pancreas, and sometimes they can be mixed. Mucinous cystic neoplasms are a little more distal, usually in the body and the tail of the pancreas, generally speaking happening in women in mid-age, 40, 50, sometimes 30. So these are the main mucinous cysts. Serous cysts of the pancreas are not super common. They tend to be benign. So the chance of a serous cystic neoplasm of the pancreas, or what we used to call a serous cyst adenoma, the old nomenclature of that, they're not really bearing any cancer risk. We operate on them if they are big, symptomatic, locally invasive. Solid pseudopapillary tumors of the pancreas are one of these very rare solid tumors of the pancreas that do have a risk to progress into a cancer. Again, happening most commonly in females, young females always. Probably see 1 or 2 a year of these, not more than that. And then there's the focal pancreatitis condition, where pancreatitis or inflammation of the pancreas happens to be in one area of the pancreas, looks like a tumor, behaves like a tumor, but it's just inflammation. And sometimes the only way to tell is to cut it out. What IPMNs we operate on? So obviously IPMNs are very, very, very common, and we had to come up with criteria to which ones are at a higher risk to progress into a cancer, and which ones need to be resected versus which ones need to be surveyed. A bunch of pancreatologists and pancreatic surgeons and specialists about the pancreas were meeting every few years in a different city. Used to be Sendai, and then the Sendai criteria came out in 2012, and then Fukuoka criteria came out in 2016, and now currently we have the Kyoto guidelines for the management of IPMNs in the pancreas. So basically we have, I don't know if you can see these are small, some high-risk stigmata and some worrisome features. And if we do have high-risk stigmata, basically if you have an obstruction of the tumor and the patient's jaundiced, if you have a mural nodule that's 5 millimeters or larger inside of the cyst, if the main pancreatic duct is blocked to a point, it reaches about 10 millimeters, or if we cannot rule out the cancer by cytology, these are high-risk stigmata. These come out, basically. And we're talking here about the side branch IPMNs. Obviously, main branch IPMNs are always an indication for surgery in surgical fit patients. And then We have a bunch of other criteria for worrisome features, which are not really a clear-cut indication for surgery, but it's almost there. And there are diagrams that take us into really following these patients and deciding whether or not these patients will need surgery in the future or just surveillance in the future. I have to say that operating on side branch IPMNs is super rare. Although we do see lots of pancreatic cysts in our practices, the chance of an IPMN, a side branch IPMN, to need surgery, it's super low. And then the pancreatitis part. Pancreatitis is super difficult sometimes to deal with. It's basically surgery for inflammation of the pancreas. And over the years, with the progress in critical care and the progress in endoscopic and minimally invasive interventional procedures, we don't really get to do much surgery on pancreatitis anymore, especially acute pancreatitis. In the past, we've used to perform necrosectomies of infected pancreatic necrosis, basically after they fail medical management and they're septic and they do require source control. I really can't remember the last time I did a necrosectomy, probably maybe 7-8 years ago. And then most commonly that are still done surgically at some point are the drainage procedures with the gastrostomies, basically. And I have a picture of those. These have been replaced now with endoscopic management, endoscopic cyst gastrostomies, which has become the gold standard in treatment of pancreatic pseudocysts. This is one of the pictures, again, we made. It's a little diagram that shows how we connect the pseudocyst of the pancreas to the stomach, basically. It's called an internal drainage procedure. We drain the cyst into the stomach or into surrounding bowels, sometimes the jejunum, basically to return the leak, the pancreatic leak, into the bowel where it's supposed to be. We don't do this much anymore. Again, it's been replaced by endoscopic cyst gastrostomies, which is a much less morbid procedure, basically without any incisions, with great success rate. I know Dr. Hawk will like this. And then chronic pancreatitis, I have to say that we still do perform surgeries for those. It's not super common like in the past, but we still do perform some of these. And the indications to do these surgeries are basically stemming out of what chronic pancreatitis is, which is really a continuous inflammation of the pancreas that doesn't stop, and it results in changes in the anatomy of the pancreas and the function of the pancreas. It basically replaces the gland with fibrosis. It becomes so tough and so hard to a point where surrounding structures are affected by the degree of inflammation and scarring that happens around them. We know the pancreas is surrounded by all types of organs, and they can be directly affected by fibrosis of the pancreas, in addition to insufficiencies from the loss of function of the pancreas, whether endocrine or exocrine insufficiencies. And surgeries do improve in these insufficiencies, however, not to a great degree, but it is helpful. And then chronic symptoms and chronic pain, a bunch of these patients end up being chronic pain type patients, and we do believe with the right surgical procedure we can help these patients. And these are some of the indications for surgery on chronic pancreatitis: symptoms, chronic pain, recurrent acute episodes, biliary strictures, gastric outlet obstructions, duodenal obstructions. Again, whatever is being affected around the pancreas mainly. Sometimes we do operate on them because we cannot rule out the cancer. Chronic pancreatitis is definitely a risk factor for pancreatic cancer. And then most of these times we end up operating, it looks like a cancer, we cannot rule out the cancer, and it ends up being just inflammation and chronic pancreatitis on final pathology. And then pancreatic divism, which is the failure of fusion of the two parts of the pancreas, resulting in inflammation of the pancreas down the line. It happens down the line in patients, although they had it, they were born with it, but for whatever reason, it does happen later in life. again, endoscopic management of these have become the golden standard. We still do perform surgeries on some of them, again, very rarely. Excuse me. Surgeries for chronic pancreatitis and any pancreatic surgery in general it's either a resection or a drainage procedure. A resection is removing the part of the pancreas that's affected, that's inflamed, that's scarred down. And it's really based on the anatomy of where the inflammation is, or the problem is, the blockage is. And it can be either in the head of the pancreas, the body, or the tail. I would say that most of these do happen in the head of the pancreas. Total pancreatectomies are used in some centers across the United States. We don't have experience in those. Can't say that works more than 50% of the time. With islet cell transplantation, we don't do these at our institution. And then there's drainage procedures. Basically a bunch of names for different kinds of procedures. If you're draining the head of the pancreas, or if you're draining the body of the pancreas or the tail of the pancreas. I have a couple diagrams here to show you the anatomy of some of the main procedures that we do. This is a Whipple procedure with the tumor in the head area of the pancreas, or the area of pancreatitis, or the scarring is in the head of the pancreas. It's super important to tell the patients what organs come out in a procedure. We do perform an enterectomy, which is removal of the distal part of the stomach with the specimen, in addition to the head of the pancreas and the bile duct that goes through it, in addition to the whole duodenum and the gallbladder. Gallbladder, for whatever reason, is super important for patients. They care so much about it. It comes out. And then the reconstruction, we bring that part of the jejunum and hook it back up to the pancreas, the bile duct, and to the stomach. Why does the gallbladder have to go? I have to ask this question and answer this question all the time. It basically boils down to direct involvement, number one. Number two, vascular supply, arterial supply, venous supply. And number three, we have to cut the bile duct, basically where the cystic duct meets the main bile duct. So gallbladder has to go, can't stay, basically. And then there's a diagram about distal pancreatectomies, where the tumor or the involved part of the pancreas is in the body tail area of the pancreas. There are different basically sizes of distal pancreatectomies. It depends on how much you remove, up to an extended distal pancreatectomy, which goes all the way to the neck of the pancreas. Spleen comes out in cancers. Big debate on whether or not spleens need to come out in benign diseases of pancreas or pancreatitis. Problem is, and this is the next question, why does the spleen have to go? It's basically the anatomy of the blood supply to the spleen. While the spleen itself doesn't have to come out, the blood vessels going to the spleen, sometimes it's super hard to dissect them off of the tail of the pancreas, so they have to go. And if they have to go, then the spleen remains without any blood supply or venous drainage, and this is why it has to come out. We try our best, though, to perform a spleen-preserving distal pancreatectomy in patients with benign or precancerous lesions of the tail of the pancreas, or focal pancreatitis of the tail of the pancreas. I know I don't have much time in this presentation. It takes a long time to talk about pancreas, but I have a nice case here that I happen to take care of in the last couple of years. This is a young patient, 48 at the time. Met him in 2023 with acute pancreatitis, or in 2023 he started having acute pancreatitis. I didn't meet him at the time, but he had his gallbladder removed at the time, thinking that his pancreatitis was related to that. Not sure really if it was related to that. And then after his cholecystectomy, he recovered well, but his symptoms started recurring with acute onset of abdominal pain and needing to go back to the emergency room a bunch of times and be admitted a bunch of times. He had an ERCP in May of that year, a couple months after his gallbladder surgery. They found sludge there. Additional workup that we have include all the time in pancreatitis is autoimmune pancreatitis, which he did not have. His symptoms kept on getting worse. with pain, weight loss, anemia, maybe some nausea, vomiting, not tolerating food. He ended up being seen in multiple other places, including Hopkins, in October of that year, where they did an MRI and they found that he has inflammation of the groove between the head of the pancreas and the duodenum, basically. Bile ducts were not dilated at the time. His lipase was fluctuating between 100 and 1400. And then I saw him the first time when Dr. Hawk asked me to see him, which was about a year later from his cholecystectomy. And he was admitted to our hospital. Dr. Hawk had stented his pancreatic duct previously, and that did not work well, with his symptoms being continuous. So he removed his pancreatic duct stent and then asked me to see him to see whether or not he would be a surgical candidate. At the time, I have a couple slices here of his scan. You will see the neck, the body, and the tail of the pancreas being almost normal. I'm not going to say 100% normal, but almost normal. But then when we get to the head area of the pancreas, there's a big mass-like inflammatory phlegmon. Very angry, very inflamed head of the pancreas area. And this was his stent, basically, that was placed at our institution by Dr. Hogg. I have to mention here in parentheses the great collaboration and the great teamwork in a multidisciplinary fashion that we have at our institution. So that's the stent in the head of the pancreas area. You can see how angry that area is. Huge phlegmon. Now in retrospect, if we didn't know better, we would have said this is a cancer. Again, additional cuts of that. You can see where the duodenum, this is a coronal cut where the duodenum is really trying to go through that area, but then it disappears in that area. So it's like a gastric outlet obstruction / duodenal obstruction type problem. This was an MRI that was done after we met him in May of 2024. Again, it did show that area in the head of the pancreas with really a tapering of the pancreatic duct as it goes into the head of the pancreas, and it basically disappears with a little dilatation of the rest of the pancreatic duct in the body and the tail. Again, the duodenal area is super inflamed. The bile ducts were not very dilated at the time. His lipase was a lot around that time, again, being admitted multiple times with recurrent pancreatitis. So we basically met him. It took him a little time to decide on how to proceed, but he obviously needed a Whipple procedure for this big inflammatory change in the head of the pancreas area. And given that the rest of the pancreas appears within normal or close to normal, so we proceeded with the Whipple procedure on him. July 1st, 2024, he did well. Hospital stay, I have to say, is around 5 days, on average 5.2 days for us in this institution. It's about now 10 to 11 days nationwide. It was uncomplicated. Complicated. His drain was removed prior to discharge, and then we saw him at the follow-up visit a couple of times post-operatively on a weekly basis. Did well, progressed as expected. And then the specimen on pathology showed chronic active pancreatitis with abscess formation and prominent fibrosis. No cancer in there, luckily. This is the specimen, basically, and this is exactly what the Whipple specimen is like. So we have the distal part of the stomach, or the antennal of the stomach, and then this big phlegmon in the head of the pancreas area that really replaces all the head of the pancreas area. This part of is the rest of the duodenum. I always take pictures of my specimen. I think it's very interesting, and nowadays patients like to see them. And again, on follow-up visit, patient basically went back to his normal life, back to work, back to eating, not having any symptoms, not being on any narcotic type medications. I have a scan on him from last month. Basically, this is the body and the tail of the pancreas. See how nice and thin and normal, and you can't even see the pancreatic duct, which is nicely drained. And this is the head of the pancreas area where it was, and it's now basically a connection between the intestine and the neck of the pancreas area. really you can see the nice black planes around that without any evidence of inflammation. So this is an example of a big surgery, a Whipple procedure we did for chronic pancreatitis on a young guy with really no other issues, and he recovered very well. He basically gained his normal life back after that. I think we're running close to time here. I wanted to include a few things. Again, I'm taking advantage of this to take about our program throughout. And the last 10 years, we had a bunch of publications. You can look me up, but I'm proud of a couple publications. Basically, we were one of the very early groups in the country to rely on a full liquid diet on discharge. So we basically took that idea from the bariatric surgeons at the time. We used to think that everybody has to be on a regular diet or a soft diet before going home, and we realized not really. We don't have to. So everybody goes home on a full liquid type diet after discharge, and then we'll be seeing them on a weekly basis and advancing their diet back to a regular diet within a couple of weeks max. I would say not more than a couple of weeks. Delayed gastric emptying is always an issue in Whipple procedures. The rate in delayed gastric emptying in our series is really not much, but I don't think it's related to how we do things. It's probably related to taking our time before getting to a regular diet afterwards. I have a book chapter that basically I did when I was still in Milwaukee for my fellowship with Dr. Doug Evans, my mentor there, and we talk about techniques of vascular resection and reconstruction in pancreatic cancer and Whipples in general, since cancer is most of what I do. This is a nice chapter for anyone who's technically inclined in knowing how we do things. I do describe in detail, step by step, on how I do my Whipple procedure and how we perform our vascular resections and reconstructions. Again, big thanks to our teams over the years. We used to be a big part of PanCan in DC, Pancreatic Cancer Action Network. We used to participate in their walks. I haven't done that in a couple of years. I have to say I'm slacking on that, but hopefully we can go back to doing that. Big thanks to our team here at VHC. These are basically a bunch of our educational dinners. The team in the operating room has been amazing to me. Really, we hit the ground running. I was doing Whipples basically first month I joined VHC. I have to say they look different when we're outside having dinners. But again, big thank you to everyone who made this possible, and thank you for including me in this talk, and hope to see you soon in person. Thank you.